Hello and welcome to this session of Maritime Medicine, in which we discuss the general principles and assessment of trauma patients.
At the end of this session, you will be able to define blunt and penetrating trauma, list at least 4 signs and symptoms of serious trauma that will require evacuation, and describe and perform the initial assessment and secondary survey for a traumatically injured patient. So, medically speaking, what is trauma? Basically, anytime you transfer energy in any form from one source to another, such that tissue damage occurs, trauma has occurred. And how much that trauma causes an injury will depend on location, how much energy is applied, how long it's applied. And those 3 things really are it. Generally speaking, we divide physical trauma into 2 types, blunt and penetrating. We also talk about burns or electrical injuries, but those aren't really categorized in these 2 schema. This defines most of the trauma that we've seen. In blunt trauma, there's force. The blunt object doesn't penetrate the body necessarily, although it can if there's enough force applied. The disruption of the tissue doesn't go all the way through the skin. So you can be hit by a hammer and have a superficial laceration or cut from that, but it's not an injury that penetrates deeper than the skin level. However, because of the compressible nature of soft tissue and the fluids and the incompressibility of the fluids and the transmission of energy through fluids, the forces can be passed through to internal structures. So just because you're hit in the abdomen with a baseball bat and it doesn't open up your abdomen doesn't mean that the force isn't transmitted directly to your spleen or liver. And with blunt trauma, while there can be focal blunt trauma, like what you would see if you were hit with a baseball bat or if you fell and struck just one part of your body onto a railing, generally these are the injuries that really tend to be systemic and diffuse. So the motor vehicle accident, the fall from height, where there's energy that's spread over the whole body and you get multiple different organ systems injured and involved. In penetrating trauma, there's a force applied by a blunt or a sharp object. We think of sharp objects in penetrating trauma, but being hit hard enough by a blunt object can do this as well. And the skin gets opened up and there's the object itself enters into a body cavity. And the injury is caused by direct contact with that object. And again, you can get the same transmission of energy through the incompressible fluids and injure other organs, but the major injuries tend to be from the object themselves. And because of that, they tend to be localized there. And this is the typical knife and gun club person-on-person violence. Trauma is not inconsequential. It's the leading cause of death for Americans under 37 years of age. Beyond that, we get into medical issues, but for people who are really in the early working primes of their life, this is a major issue. It's the 5th leading cause of death in the U.S. as of 2011. There tends to be about a 10-to-1 ratio of blunt to penetrating trauma, which is good given that penetrating trauma tends to be person-on-person. It's also good in that survival is better for blunt trauma. About 3/4 of people who suffer blunt trauma survive. About 2/3 of people who suffer penetrating trauma survive. And we're talking about major blunt and major penetrating trauma. We're not just talking about I whack the back of my hand with a hammer. Now, shock is covered in greater detail elsewhere, but shock is really the key to looking at death, mortality, and injury, morbidity in trauma. Shock is defined as inadequate end organ perfusion. What does this mean? Not enough oxygen getting to your organs. And there's lots of things that can cause that. But in trauma, it's basically blood loss. You lose blood, your blood pressure drops. You lose blood, you can't carry oxygen. Those things together keep your organs, your brain, your heart, your liver, whatever it is, from getting enough oxygen, and those organs die. And that's what we're fighting when we're fighting against death and taking care of the trauma patient. So when you're assessing a trauma patient, what you're really looking for are clues to shock. You need to know if your patient is going into shock. And while these signs and symptoms certainly overlap with other conditions that aren't shock, you really have to pay attention to these in all patients, and in particular in your trauma patients, when you're worried that they may have a significant injury. Obviously, if their abdomen is ripped wide open and you can see their bowel, you don't need to go looking for other more subtle signs or symptoms of shock. You know they're going to go into shock. But particularly in blunt trauma, the injuries can be very subtle. It can be difficult to tell what's going on. Your only finding of severe abdominal injury may be a small bruise over the upper right quadrant. And then you need to look for these more subtle signs and symptoms. So people who are anxious or restless, their mental status has changed. They're not unresponsive, but they're just not themselves. Or they feel dizzy, or they're nauseated, or they feel thirsty because the body wants to increase your blood volume when you're losing blood. Those are all symptoms that would make you think that somebody might be going into shock. And then signs, that agitation and confusion. When we go into shock, our body releases a lot of adrenaline, a lot of epinephrine. And what it's trying to do is squeeze down those blood vessels, get more blood volume to the heart and to the core organs. And part of that is that fight and flight response. And so our pupils get big so that we can see all the threats coming at us at the distance there and when they come up close. And so this is a finding that you'll see, these dilated pupils. They may start to sweat. They may have pale and cool skin as they start to cut off blood supply out to their periphery. Their breathing becomes shallow and rapid because they're trying to get rid of excess carbon dioxide, but they're not doing it effectively. So the rapid breathing helps, the shallow part doesn't. They may have a lower falling blood pressure, although that's a very late sign. They may have a rapid weak pulse. That's an earlier sign. So if you see a patient whose heart rate is up, and particularly if it was normal when you first evaluated them, and now it's going up, and then on the fourth set of vital signs, you notice their blood pressure is going down. Those are all very ominous signs. And finally, if you're tracking this patient over time, you've got them in the sick bay, you're stuck there for 24 hours till you can get them evacuated, and they're making less and less urine, that's a sign that they're cutting off blood flow to their kidneys and trying to get blood to the more core organs. And they do this in response to shock. And in doing so, they have less urine output. So now we're going to talk about assessing the trauma patient. And for you, the key point is to differentiate whether someone is sick or not sick. And the sick patients need immediate evacuation. The not sick patients, you need to talk to medical control. They may end up needing to be evacuated, but they may not. And we're basing this on the 2011 CDC guidelines for field triage of injured patients, which is written for EMS providers, but is useful in the shipboard environment as well, because it tells you who needs to leave immediately and who you can have a conversation about. So, as always, body substance isolation, you're seeing safety, you're looking for threats to your life. Your safety, crew safety, is more important than anything else. Once you get to the patient, control exsanguinating hemorrhage, assess their airway, breathing, and circulation, neurologic status with disability, expose them to find injuries. And in trauma patients, you really need to do this. A medical patient, not so much sometimes, but in a trauma patient, you need to expose them, and then you need to protect them from the environment, and then you need to find scene clues. And in trauma, that's going to be particularly important for you because you may not have bystanders or witnesses, but because of the way that trauma occurs, it's a physical event, and you can often find the entire story on the scene that explains to you what happened. So, is the patient sick? In your XABCDEF assessment, if their Glasgow coma score is less than 13, if their respiratory rate is less than 10 or greater than 29, or if you need to help them breathe with a bag valve mask, then they are sick, and you need to be thinking about how you're going to get rid of them immediately. If in your initial assessment you don't necessarily find anything that says, okay, this patient is desperately ill, I need to get rid of them, then you do a focused history and obtain vital signs. There, your real key finding is in an adult, a systolic blood pressure less than 90. Unless they tell you that my blood pressure always runs 80 to 90, and some people do, if they can't tell you that, or if they tell you, no, I've never had a low blood pressure, that's a sign that they are sick and you want to get rid of them as quickly as possible, because otherwise you are going to be resuscitating them hard, and what they really need are bright lights and cold steel. They need to go to an operating room, figure out what's going on, and that's not something you can do shipboard. So after you've done your initial assessment, you don't find anything that points to the patient being very ill. You do your focused history and your vital signs. You don't find anything there that's a red flag. Now you want to do your physical exam. And what do we examine in a trauma patient? Everything. Keep in mind, shipboard, it's not like you're on a scene that you're going to throw a patient in the back of an ambulance and get them to a trauma center in 10 or 15 minutes. Even if they're critically ill, you're stuck with them for a while. So you need to do a good full physical exam to figure out what's going on, make sure you're not missing any injuries. So you examine the head, the face, the neck, the chest, the abdomen. You examine the stability of the pelvis. You examine the spine. You examine the extremities. Anything that you can get to, you examine. And what are we looking for? We're looking for stable decapitation, STBL, DCAP. That's swelling, tenderness, burns and lacerations, deformities, contusions, abrasions, and penetrations. If you can find those are clues as to what injuries happen. So that's what you're looking for. Now, aside from that stable decapitation, there are going to be some regional specific findings. So for any given body part, there's additional things you may find. So you look for stable decap over every body part you examine. But in the head and face, you're looking for a couple of additional things. You're looking for cerebrospinal fluid. That's the fluid that surrounds the brain. If you break the skull, particularly the base of the skull, that leaks out. And it will leak out of the nose and it will leak out of the ears. And in particular, the nose, there's a very thin bone that separates the brain from the outside world there, the cribriform plate. And if you break that, you will have what looks like thin, clear snot pouring out of the nose, and that's a very bad sign. You also want to, if there's any evidence of facial injury, hold the upper teeth in your hand and wiggle it. And if the whole face wiggles with them, bad sign. You want to make sure that the pupils are reactive to light, and so you need to make the area somewhat darker, and you can do that just by putting your hand over the patient's eyes, because you don't want to hinder your ability to do the rest of your exam. When you lift them up, the pupils should go from dilated or big in the dark to small in the bright light. And you want to make sure that the eyes move, and they can move in all directions, all the way to the right, all the way to the left, all the way up, all the way down, and that they do this symmetrically. Otherwise, if there's any evidence of facial trauma, you're worried that the orbit has broken and the muscles of the eye are stuck in that fracture. On the chest, you want to assess their respiratory rate, how hard it is for them to breathe, and how deeply they're breathing. You want to look at the trachea, which is, of course, the structure that connects the upper airways down into the lungs, and you can see it in the midline just below the Adam's apple or voice box, and you follow it all the way down to the notch at the top of the sternum where the collarbones come in and attach to the sternum. That's called the sternal notch. And if somebody has a tension pneumothorax, they've got air collecting in one side of the chest and it's under high pressure, late in that injury, the trachea will begin to push to the unaffected side at the level of the sternal notch. You want to listen for abnormal or noisy breathing to make sure there's not an upper airway injury, blood in the upper airway. And you want to look for parts of the chest that are moving in opposite direction of other parts of the chest. It's called paradoxical breathing, and it happens when you have a flail chest, which is discussed elsewhere. When you get to the pelvis, you put the palms of your hand on the wings of the pelvis and you gently push backwards. You should feel a good amount of resistance to doing that. If you don't, if it seems to compress, that's a sign of a fracture of the pelvis. In addition, if you see blood at the tip of the penis or the opening of the urethra in females, or any blood at the rectum, that's a very bad sign that there's internal bleeding from a pelvic injury. And the problem with the pelvis is its incredible amount of vasculature blood vessels that lay right on the pelvis, and if they get injured, it's very easy to bleed to death in that area, and it's incredibly hard to control that. For the abdomen, aside from looking for a stable decap, you also want to see if the abdomen is rigid. When you push on it, is it firm and hard to push? And it's not just because it's tender that it does that, but the blood irritating the peritoneum, causing a peritonitis, actually puts the abdominal wall muscles into spasm, and that makes them rigid. And you also want to listen for bowel sounds. And on the extremities, you want to check and make sure that there's distal pulses, that they're able to move their fingers and toes, and that they have normal and symmetric sensation in their fingers and toes. So during your physical exam, there's things that will tell you that this patient is sick and that you want to get them evacuated as quickly as possible. And that's in the anatomy of the injury. So any penetrating injury to the head, neck, torso, or close to the body, proximal to the elbow or knee, bad sign, get rid of them. If the chest wall is unstable, either when you press on it, it's crispy, crunchy, and moving in the wrong direction, or you see paradoxical movement where part of the chest seems to be moving in the opposite direction of the rest of the chest, bad sign, get rid of them. 2 or more proximal long bone fractures, so the humerus and the femur are considered the proximal long bones, the humerus in the arm, femur in the leg. If those 2 or more of those are broken, that's a lot of energy to do that. Those patients need to be evacuated. If they've have an extremity that's been crushed or mangled, or the skin's been pulled off, or there's no pulse to it, that's really bad too. They need to be evacuated not necessarily for the life threat, but for the limb threat. If there's an amputation above the level of the wrist or ankle, they need to be evacuated. And again, it's not necessarily for the life threat, because you can very easily have an injury that just causes an amputation in the mid-forearm, but you've got a limb threat there when that happens, and you may be able, depending on the injury and how mangled the tissue is, you may be able to get them somewhere where that limb can be reattached, what's called reimplanted, and then they get function back, and that's great. Any evidence of a pelvic fracture, because of all those blood vessels in there and their risk of bleeding, they need to be evacuated. An open or depressed skull fracture, so if you're examining the head and you push on part of it and it's really mushy and your fingers seem to be going deeper than the surrounding bone, or you look in there and you're like, that looks like brains, that's a bad sign. You got to get those folks evacuated as quickly as possible. And any paralysis, so can't use an arm, can't use both arms, can't use the legs, any extremity where you've lost motor function, or really sensory function. Motor function probably more important of the two, but sensory function also very concerning. You need to get them evacuated. If on your initial survey, your focus history, your vital signs, and your physical exam you don't find anything that's red flagged that says this patient is sick and need to be evacuated, you then need to look at the mechanism of injury. And the mechanism of injury is, how did it happen? And if there's any evidence of high energy transfer, that is, that because of the way the incident happened, a large amount of energy got transferred from the environment into the patient, then those are red flags. And so falls for adults, a fall of greater than 20 feet, and that's 20 feet at your feet, not really 20 feet at your head, because otherwise a fall from standing would be considered a 6-foot fall for me. That's not the case. You measure basically from the feet to the ground, or from their lowest point to the ground, how far did they fall. For children, it's a fall greater than 10 feet or 2 times the height of a child. And we're not talking about parkour here, because that's all about landing and rolling. We're talking about an unintentional fall with a lousy landing where there was immediate transfer of energy into the patient. Also, any high-risk motor vehicle collisions, that includes high-risk boating incidents where there was a good deal of damage to the vehicle, where there was a lot of energy transfer from the vehicle into the patient. Those are all red flag findings. So you've gotten through your initial assessment, your focused history, your vital signs, your examinations. You've looked at the mechanism of injury. Still nothing is screaming at you. We've got to evacuate this patient. Now there's some findings that are concerning, but you need to discuss them with medical control. So any child less than 12 or greater than 55 who suffered trauma, they're at higher risk of dying from their injury if they have one. So if there's a reason to think that they have a significant injury or may have a significant injury, you may want to evacuate these patients sooner than you would someone who was older than 12 or less than 55. If they're on any blood thinners, you need to be very concerned, particularly if they have a head injury or they have a moderate high energy transfer event where they could have an internal organ injury that you just can't see. The same is true with bleeding disorders. We'll talk quite a bit about burns and what criteria you should use for evacuating burn patients. For the most part, you're going to keep only the most minor burns shipboard. Anything of any consequence you're going to want to evacuate, because just pain control alone is incredibly difficult for these patients. And anyone who's pregnant greater than 20 weeks, you need to consider, do they need to be evacuated depending on the injury. If it was a blow to the forearm, a blow to the humerus, maybe not so much, but any abdominal injury, any chest injury, you're worried both about the changed physiology of the mother being pregnant, and you're worried about the survivability of the fetus. And that's why we use the 20-week cutoff, because under 20 weeks, even if the mother went into labor, premature labor, and delivered, there's really no viability for that fetus. So you think about all these things, you think about the injury, and you discuss it with medical control and make a decision about evacuation. So in short, you have a trauma patient, you need to figure out, are they sick or not? And by sick, we mean they could die on you pretty easily, and you need to get them out, get them to shore, get them evacuated. So if their Glasgow coma score is less than 13, their systolic blood pressure is less than 90, their respiratory rate is less than 10 or greater than 29, they've got an anatomically significant injury of the type we've discussed, there was a high energy transfer mechanism of injury, where even if you're not seeing an injury, you know that the potential is very high, or there's some special circumstances and you discuss it with medical control and agree together that the combination of the mechanism of injury and those special circumstances make the patient at risk for being very ill, then you need to evacuate the patient. One other point in terms of general trauma management principles, and that's the concept of permissive hypotension. So in our trauma patients, we give them IV fluids, and it's probably not a bad thing because we don't want them to have no blood pressure at all from shock. But the problem is the body is trying to plug up all the holes from the trauma, and it does this by forming clots, and we don't want to wash out those clots. We used to try to get patients' blood pressures up to the normal range, and what we found is they died at much higher rates. And the reason why is once we build up the pressure in the vascular system, we were just washing the clots right out. So now we do what's called permissive hypotension, and we aim to keep their systolic blood pressures at about 80 to 90 millimeters mercury. If they have head injuries, we go a little bit higher, 90 to 100, because we want to keep good blood flow to the brain. But generally speaking, we're aiming in our trauma patients for systolic blood pressures of 80 to 90. That should be your goal for fluid resuscitation. Please complete any knowledge reviews, and if you have any questions, don't hesitate to get in touch with your instructor or professor. Thanks very much.